Well, first of all, it is an absolute honor to have Dr. Neil Baer with us. For those that may not know, he was trained as a pediatrician. He is the Emmy, Golden Globe, and Peabody Award winning executive producer and director of numerous shows that I think you'll recognize. Designated Survivor, starring Kiefer Sutherland on Netflix, ER and Law and Order Special Victims Units on NBC, Under the Dome, and the medical drama A Gifted Man, CBS. He is also an executive producer of the new documentary film Welcome to Chechnya, which won a special jury award at the 2020 Sundance Film Festival. The film premiered on HBO in June. And I'm going to put a spoiler alert. We are actually working on another event coming up where we are going to do a screening here at Yale with a full panel, also led by Neil Baer. So that will be announced in the future. Dr. Baer received the Valentine Davies Award in 2004 from the Writers Guild of America, and in quotation, for public service efforts in both the entertainment industry and the community at large, bringing dignity to and raising the standard for writers everywhere. Tremendous honor. He is a lecturer on global health and social medicine at Harvard Medical School and was previously the clinical professor of preventive medicine at the Keck School of Medicine at the University of Southern California, an adjunct professor in the Department of Community Health at the Fielding School, where he established the Global Media Center for Social Impact. I want to say, and Sten now is in the background, that we are really proud that he recently joined our school as a lecturer in the Department of Chronic Disease Epidemiology. And he is both a creative and very welcome collaborator for our new initiative, Humanities and Public Health Practice at Yale, known as HAPPY. So please, Sten, anything you wanted to say?
No, just welcome to Neil. Welcome to the faculty, Neil. And we want to all welcome you for your talk. Science is just another opinion, the battle between facts and anecdotes. Quite a title, Neil. You're on.
Thank you so much. Thank you, Dean Verman and Professor Lichtman and Connie Evans and Karen Deary for making this happen. We might have a few little moments of pause when I go to show you some clips from my shows, but we'll just bear with me. So I shall begin. So how can we as healthcare providers, public health policymakers, and those committed to advocating for healthcare equity draw on our work to tell stories that can make a difference in people's lives? As a pediatrician and television writer, I'm in the unique position to promote public health through dramatic television stories that are grounded in data. By telling emotionally compelling stories that are informed by peer-reviewed research, we can improve public health, particularly in these COVID-19 times when conspiracies and anecdotes swirl around and crowd out the science. Today, all of us are fixated on what it means to be infectious, derived from the Latin infancere, to spoil or stain. The word itself is emotionally resonant, striking fear and warning us to stay back, lest we become spoiled by or contaminated with COVID-19. There's an inherent blame in the word too, placing the onus on the infected to keep their distance from those of us who are clean and untainted. Though we toss the word infectious around daily, the science surrounding COVID-19 is still emerging. We don't know yet what levels of COVID-19 virion SARS-CoV-2 constitute an infectious dose, what viral load means for COVID-19 in terms of morbidity and mortality, who is genetically more susceptible, who is a viral shedder and who isn't, and why some people appear to be asymptomatic. We have ideas informed by the data we have to date, but we need more data not only to understand COVID-19 better, but also to formulate treatments. That is why we mask and social distance. The public health policy of masking and social distancing come from the best evidence we have today, along with our experience with past pandemics and what we know scientifically about the airborne transmission of other respiratory viruses. We must keep our distance until we have a vaccine or clinically tested and verified therapeutics, not only to protect us from the clearly infectious, but also to protect the community from those who may be asymptomatically infected. The challenge of telling the COVID-19 story is that the science behind the data is dynamic and provisional. People understandably want the facts, but the science is not yet firmly established, and that can lead, as we have seen, to conspiracies and anecdotes that question the public health policies that are now in place. COVID-19 has been viewed as an us against the pandemic, and us against the infected pandemic, in which the right of the individual has come up against the safety of the community. Must it be against? Isn't what's good for the community when protecting against an invisible enemy like COVID-19 also good for oneself and for one's family? The pandemic, as tragic and horrendous as it has been, has aimed a spotlight on stories that show us how we're all in this together and illuminate the chasms in our healthcare system, particularly in access to quality care for the impoverished and people of color. We must tell those stories. I want to explore how we can use data to tell emotionally compelling stories and why that's important in promoting public health. In 2006, I explored the idea of infectious and used it to reframe a public health story on the television series Law and Order Special Victims Unit. Back then, I was trying to make a connection between gun violence and infection to fashion the argument in terms of a public health issue beyond the right to bear arms. Drawing on a research study published in Science, which concluded that exposure to firearm violence approximately doubles the probability that an adolescent will perpetrate serious violence over the subsequent 2 years, we created an episode of SVU to articulate what was then an original way of looking at gun violence. Here is dialogue from the scene taken directly from that episode of a little boy, Nathan, on trial for murder. The defense attorney is speaking to the jury. Okay, so I'm going to show you the clip.
Let me just, what you saw was a program that Neil was the scriptwriter for. And this is what he does. He nests public health and health messages within his drama and provides a public educational tool to actually educate people in a completely alternative way through drama, through television, and the like. So that's what he saw. And he's been doing this for a couple of decades now with a whole raft of shows, including ER. And some of the first commentaries on HIV, AIDS were on ER. Here's the one we just saw on gun violence. And he's done it on a whole raft of other topics. So hopefully he'll be back with us in a moment and give us his commentary and show us another clip.
Oh my goodness.
Hey, Neil, you're back.
Okay, let's see where we are. I apologize for that. This is crazy. We probably shouldn't dare show the other clip because it did something really bizarre. But here we go. All right. Thank you for everybody for your forbearance. All right, we began that scene that you just saw, not with a presentation on gun death statistics or data from the research study in Science, but with a story about a little boy who was exposed to gunfire without his choice. His defense attorney then made a public health argument, marshaling data from the study, that by witnessing gun violence, Nathan was infected with a propensity to commit a violent act. The gun is like a virus, this study shows. Once adolescents actually see someone fire a gun or see someone shot, they are infected and at least twice as likely as those who are not exposed to commit a violent act, the disease, in the next 2 years. Importantly, the story itself was inspired by data from a study published in Science, but we didn't lead with the research findings. Instead, we told an emotional story and then supported it with data. That approach, drawing from the research to create an emotionally resonant story, is important for all of us who seek to inform the public. Unfortunately, we must compete with those who strive to change hearts and minds by employing alternative facts, which become amplified in the nearly impenetrable echo chamber of social media. Today, I'll explore how we can use our own stories based on and supported by the rigors of science to promote public health and counter the dangerous misinformation promoted across the internet. Take, for example, vaccines, which are on everyone's mind today. We need to think hard about how we tell the story about them. If a journalist asked those of you who are public health policymakers to discuss the state of vaccines and their development amidst this pandemic, would you immediately go to the data? Or would you begin with a story that engages the viewer, listener, or reader? As data-driven as many of us must be in our work, it's crucial to tell our stories in emotionally compelling ways that do not lead off with the data. Paul Slovic, a professor of psychology at the University of Oregon, has influenced a range of writers and academics, including New York Times op-ed writer Nick Kristof and Nobel Economics laureate Daniel Kahneman. Slovic has shown experimentally that human beings are hardwired to be story-driven. We're not, in general, moved by data. I'll return to this point about what it means to be hardwired for storytelling later in my talk. Here's an example of the power of one. Think of the story of the sea turtle suffering with a plastic straw impacted in its nostril. That story moved millions and led to legislation banning plastic straws. But if we tell people that each year more than 8 million tons of plastic are dumped into the oceans, it barely registers. How does one conceive of 8 million tons? And what can one person do about it? Examples of stories changing legislation and people's awareness abound. Today, Anne Frank's story profoundly moves us. We're drawn to her bravery and heroism, and we can then imagine the untold Anne Franks who lost their lives battling hatred and fascism, the 6 million Jews who perished in the Holocaust. Concepts like fascism, anti-Semitism, and racism are more clearly understood when they are epitomized in deeply moving stories of struggle, as we have witnessed more recently in the massive protests for social justice and equality after the murder of George Floyd in Minneapolis. In medicine, think of the impact of the Tuskegee experiments when they were chronicled in books and the play and film Miss Evers' Boys. Folks became aware, folks spoke out, folks saw human beings, not numbers, and they were moved to action. Another medical example of the impact of storytelling is the best-selling nonfiction work and TV movie, The Immortal Life of Henrietta Lacks, which raised the question about who has the right to profit from a person's DNA. Slovic posits that we're wired evolutionarily to deal with the few, to protect those immediately around us, like our families. Not only do we feel impotent to deal with all that plastic in the oceans, but he argues that we have difficulty conceiving of that amount. But when we see one suffering turtle or human being, we're spurred to action. In an episode of SVU from 2009, drawing on Slovic's work, The Importance of Leading with the Story, in my own training as a pediatrician, we presented the case for vaccinating children. In this episode, a mother failed to vaccinate her child against measles. Her unvaccinated 5-year-old son was in the park and infectious, though not yet showing signs of a rash, when he came in contact with a little girl under a year old who contracted measles from him and died. We don't vaccinate children for measles until they are a year old. The mother of the unvaccinated boy, Ms. Stewart, was put on trial for involuntary manslaughter. I won't show you the segment, but I'll tell you about it, that she's on trial. And when the assistant district attorney asks her that it's clear that pediatricians are of the mind that children need to be vaccinated, and she has a different opinion, how does she respond to that? And she says, well, science is just another opinion. So that's the gist of that clip that I'm not going to be able to show you after all. In that 2009 episode of SVU, it was called Selfish because we sought to raise this question. What is our responsibility to our children? And what is our responsibility to the community of children? Back then, we were seeing the anti-vaxxer movement taking hold. As a pediatrician, I was deeply concerned about the consequences of parents choosing not to vaccinate their children because they had heard or believed stories that vaccinations are harmful and cause autism, or that their children's immune systems couldn't take it. Anti-vaccination anecdotes such as these collide with the science because there are no data-supported studies proving that they are true. Yet, these anecdotes are often emotionally compelling. To counter the anecdotes against vaccination, I illustrated their repercussions when they influenced parental decisions that could harm children. Tragically, we've seen my concerns become reality when children, again, dying or acquiring severe disabilities because they weren't vaccinated. One can only imagine the struggles we will face from anti-vaxxers when a vaccine is developed for COVID-19. We must have counter stories in place. The website www.shotbyshot.org, is an example of using stories to put a face on vaccine-preventable diseases. Finally, let me point out my favorite line from any show I've ever produced. Science is just another opinion. The idea that science is just one of many opinions has taken root around the world, illustrating what we're facing today. A mounting move by some to stop sheltering in place and social distancing because science is just a way for public health officials to maintain control over citizens and personal choice, and one's own ideas are equally valid. Here again, the challenge is that, unlike vaccinating against measles, the evidence for COVID-19 is not definitive. Many individuals who have children to feed and rent to pay must also struggle to make the haunting choice to go to work ill or stay home and face the consequences of having no income. The science itself is not clear yet about who is and is not at risk, though it's clear that the COVID-19 mortality rate is highest among older people. Consequently, we draw on the best evidence we have. But just because the COVID-19 science isn't definitive doesn't mean that the science we have to date is invalid. Rather, the picture itself isn't complete. We must all work to change this profound misunderstanding and fear of science, of what we know experimentally to be true, and to accept that we must often act on the best evidence we currently have. Many, if not most of us in the public health field, are laser focused on data because that is the very nature of our work, whether it's looking at survival studies in treating cancer or assessing the epidemiological impact of pesticides on human health. But for most lay people, our work is too specialized and deeply complex. That's why anecdotes are so potent. They're often emotionally riveting stories about real people in contrast to our p-values. For instance, recall last spring when Dr. Anthony Fauci described initial results using remdesivir to treat COVID-19. Many people were confused. What is a p-value, they asked? What does statistical significance mean? Is it true or not true that remdesivir reduced mortality from 11% to 8%? And if it's not true, then why did Dr. Fauci say it? A recent evocative example of being prepared for the dramatic anecdote occurred when Dr. Rick Bright, until recently the head of Biomedical Advanced Research and Development Authority in the Department of Health and Human Services, was questioned in a congressional hearing by Representative Michael Burgess of Texas. Representative Burgess began by stating an anecdote to Dr. Bright. He said, "I'm hearing from a lot of doctors in my state around the country who have experience using hydroxychloroquine and chloroquine coupled with erythromycin and zinc. And they're reporting significant benefit if it is used early enough in the course and may eliminate the need for hospitalization and ventilation." Dr. Bright responded, "I've heard those anecdotal stories as well," he noted, "and they were not conducted in the context of a randomized controlled clinical study." He continued, "It's very difficult to understand data from those types of observational studies or anecdotal stories. So the drug might have some benefit in some populations, but we won't know that until we have that information from a truly randomized controlled clinical study. Many of those studies are ongoing now. Some of those studies we're starting to see data from. Those studies in those populations tested haven't shown an overwhelming evidence of benefit from the use of hydroxychloroquine in those patients." Burgess, who is also a physician, drew on anecdotes to bolster his case for using hydroxychloroquine to treat COVID-19. Bright responded decisively, pointing out that Burgess's anecdotes lacked scientific support from a truly randomized controlled clinical study, and that we should refrain from using anecdotes to advocate for using off-label drugs to treat COVID-19 until the data are definitive. In a recent article published in Science, 3 large studies, 2 in people exposed to the virus and at risk of infection, and the other in severely ill patients, show no benefit from the drug, despite the president promoting the curative effects of hydroxychloroquine without a license to practice medicine. Anecdotes are powerful and often persuasive because they resonate with emotion and tell us what we hope to hear. To counter the anecdote, we must be prepared to discuss our findings in a scrupulously transparent way. We must tell stories that draw on peer-reviewed data, but also engage the public. How then can physicians, healthcare providers, public health officials, and bioethicists start to think about telling their stories? Sometimes it helps to reflect on what personal event in your own life brought you to this work. Was it a mentor, a story you heard or read, a family member who succumbed to a disease that could have been prevented by a vaccine, or from one where a vaccine was not yet available? Telling your personal story moves listeners because they can empathize with you, and empathy is the gateway to changing hearts and minds. Think of a time when your own heart changed after you heard a story or saw a movie or play or read a novel. You carry that story with you. It changes you, just as it has changed others, moving us along, even if it's slowly, toward healthy social change. We can never truly get inside someone else's head, but through empathy, ignited by the stories people tell, I can imagine what it's like to be someone different from myself. And that imagining, which is the nature of empathy, leads to compassion and social justice. I keep returning to the importance of telling emotionally captivating stories supported by data to change people's hearts and minds and improve public health. You might be wondering, do these stories make a difference? I wondered that too. So in 2000, I designed a story on the television series ER about human papillomavirus and cervical cancer and conducted the first experiment to assess what our audience learned from our show. With support from the Kaiser Family Foundation, Princeton Survey Research questioned a random sample of around 1,000 ER viewers before and after the episode ran. The episode was the treatment, but we didn't tell viewers to watch it in order not to bias or contaminate the sample. Keep in mind that this episode aired before the vaccine Gardasil was available in 2006. We were astonished by the results of our study, published in 2001 in Health Affairs. 53% of ER viewers stated that they learned about important health issues from the show, and 1 in 7 said they had contacted a physician or other provider because of something they saw on the series. Before that episode aired, 19% knew that HPV is associated with cervical cancer. A week after the episode, that number climbed to a stunning 60%, dropping down to 38% 6 weeks later. That drop is common in communication studies, and it points out the need for a multi-pronged approach to reinforce a message by presenting not just one story, but a series of stories. The episode of HPV raised difficult questions about the right to privacy versus the public's right to be protected from a virus, in this case, HPV. Nurse Hathaway, played by Juliana Margulies on ER, promises a young woman who had been attending sex parties with her friends to keep her HPV test results confidential. Later, Nurse Hathaway is confronted by Dr. Weaver, who says, I understand you don't want to break confidentiality, but this is a public health issue now. At least one of those boys is spreading HPV. When does the public's right to be protected from a virus take precedence over an individual's right to confidentiality? COVID-19 has taken that notion of the public's right to be protected and made it into the marquee question of the pandemic. When does protecting the economy take precedence over protecting the health of individuals and the community? Fortunately, there's less stigma today than in the past when an individual tests positive for a virus, though stigma still exists around HIV, where nearly one out of 2 African-American men who has sex with men in the southern United States is HIV positive. Soon, I hope, we'll be telling new stories about COVID-19. And those stories must be as accurate as we can make them in light of the knowledge we have today. Many people, I fear, expect science to be static, providing immutable facts that we can grab and hold on to. But science evolves as we learn more each day. Science takes time. Voltaire wrote that the best is the enemy of the good. And we see his wise words played out daily when the public demands definitive answers when we don't have them yet. What we speculate on today may change drastically as we gather more data, particularly as it relates to COVID-19. Yet, the public wants immediate answers on COVID-19, and who can blame them? Uncertainty breeds panic and can put unrelenting pressure on researchers to publish results too quickly before the data are fully analyzed, or to focus myopically on what may be best for the greatest number of people. The pandemic illustrates how some scientists have succumbed to endorsing the greatest good without deeply considering the long-term consequences. One pressing example is vaccine challenge experiments, where volunteers who have given informed consent offer themselves as test subjects to be infected with COVID-19. Arthur Kaplan and Stanley Plotkin argued recently in an article entitled "Extraordinary Diseases Require Extraordinary Solutions" that it is permissible to infect young volunteers who have given informed consent because, as they say numerous times, this is for emergency use. In other words, in times of strife, we may take questionable actions that ordinarily we wouldn't take. The authors go on to say that despite the danger, we believe it is ethical to ask now for volunteers who would be informed about the known and unknown risks. Giving informed consent for unknown risks raises the fundamental question, can anyone truly be fully informed? When we're planning to infect volunteers for the greater good, we are essentially saying that what we do may kill them so that others may live. Kaplan and Plotkin deal with the possibility of death. They say it's remote in young people. But do we know enough to say that about individuals versus populations? Do we know the long-term pulmonary sequelae in a young person who has suffered from a bad case of COVID-19? Nevertheless, the authors state that a challenge study would require controls who receive no vaccine and who might become ill. Possible rescue treatments are being tested, such as remdesivir, convalescent serum, monoclonal antibodies, and other modalities which could be used in case of a severe disease after challenge or administered as soon as virus positivity is confirmed. Unfortunately, these rescue treatments have not rescued over 225,000 people in the US who have already perished. I wouldn't call them rescue treatments, but treatments under investigation, and there's certainly no magic bullet. The point here is that we must be wary of using heightened language, extraordinary diseases, extraordinary solutions, to justify treatment for the greater good. Utilitarianism has the tendency to begin choosing whom to sacrifice. How many deaths are acceptable as we venture out in order to save the economy? Shouldn't we also be asking whether the form of our economy is worth saving, or whether we can boldly chart new models that will keep the air and rivers clean and move workers into new jobs? It's a monumental challenge, but we've seen the blue skies and breathed cleaner air. The COVID-19 pandemic has ripped the cover off the festering inequalities in this country and exposed the consequences. Who has access to masks? Who must work shoulder to shoulder in meatpacking factories? And who can work sheltered at home? Which hospitals receive COVID-19 tests and PPEs and which do not? How will we respond to the disparities COVID-19 is teaching us? In 2018, African Americans were 60% more likely than non-Latino Caucasians to have been diagnosed with type 2 diabetes. In 2016, African Americans were 3.5 times more likely than non-Latino whites to be diagnosed with end-stage renal disease. That puts them at higher risk for dying of COVID-19, which explains in part why their death rates are so much higher than those of other groups. Those data on healthcare injustice have always been there. Too many of us just haven't been paying attention. One reason is that, as Slovic cautions, data alone don't change minds and move us to action. Today, we're seeing the disparities in healthcare writ large on the news with heartbreaking stories that can link emotion with the data. COVID-19 lit a flame under the pressure cooker that is our country. It took the murder of George Floyd to blow the lid off that pressure cooker, for citizens to come together to demand an end to the endemic racism in our police forces and across all our social, political, and economic institutions. The protesters' powerful stories are alerting us to the raw pain in our citizens' lives and moving us to vote for legislators who will enact legislation to guarantee access to excellent health care for everyone, and to protect the workers who bring us our groceries, grow and pick our food, and work in factories where they are disproportionately exposed to COVID-19 by the nature of their job and lack of protective equipment. How do we tell these stories? Let's begin with us. I wonder what a partnership between healthcare providers and patients would look like, where together they tell the story of COVID-19. I see stories from doctors' perspectives or those from the patients, but what would the story look like of a doctor and patient together relating their shared journey? What might it reveal about access or being understood? How can we draw on the plethora of storytelling modalities, poetry, blogs, op-eds, memoirs, cell phone videos, graphic novels, Instagram, playwriting, documentaries, virtual reality, dance, and music to tell what COVID-19 has wrought? Science is just another opinion reveals much more than a disdain for science. It reveals a view that what I want and think is best is more important than what's best for the community. It disparages public health findings because they push up against what I want. My right to have a gun is more important than a child's right not to be shot in school. My right to go bowling or stroll on the beach is my freedom. But our interactions have consequences, as COVID-19 has shown over and over. We are indelibly connected, whether we like it or not. When we see those connections, when we see the consequences of our actions presented in compelling stories, then we can take the template of our own lives and compare it to those stories. We can begin to examine our views in a new light. We can change our minds. That is the power of storytelling. COVID-19 has offered us a reset button, and we must come out swinging. The pandemic has much to teach us, not only about COVID-19, but about how we may live in a new way, tackling problems that just months ago seemed almost insurmountable. Skies are blue in Delhi, Nairobi, and Beijing. For the first time, many people around the world are breathing clean air. Or take obesity. As we all shelter in place, we must learn how to exercise and eat well without the pull of gyms and restaurants. We have had time to contemplate what is and is not important in our lives. Will drinking a Coke open happiness or make us feel better that we are now, as Coke says, alone together? Products like sugar-sweetened beverages, which have been shown by a plethora of peer-reviewed studies to increase the risk of type 2 diabetes, cardiovascular disease, and certain cancers, seem unnecessary now, and they certainly don't make us happier. And yet, Coke is always looking for new ways to peddle soda. Just this week, Coca-Cola announced that they are teaming up with the National Center for Civil and Human Rights, the King Center, Civic Dinners, and Equitable Dinners to host a series of 6 virtual dinner events designed to spark social justice conversations and invite Americans to listen, learn, connect, and take action. Together We Must the Conversation will focus on allyship, belonging, bridging the racial divide, inclusive culture, unconscious bias, and understanding race. The brand director for Coke said that, quote, coming together over an ice-cold Coca-Cola and a great meal opens people up to new ideas and perspectives, which we know is the path to deeper understanding and greater action. So this is very much grounded in our values and who we are as a brand, unquote. Pairing an ice-cold Coke with anti-racism conversations in the US is audacious, to say the least. It's an attempt to health wash a product that has been shown to be harmful to many Americans, particularly the economically disenfranchised, and people of color who disproportionately drink sugar-sweetened beverages. This is a public health issue. Promoting a product that accounts for the single largest source of calories and added sugar in our diets is insidious on Coke's part, and it is also complex. Coke alone employs almost 90,000 people, and that does not account for all the people who supply the ingredients, market it, and sell it around the world in stores, bodegas, and kiosks. That can make the difference in moving a mother out of poverty. And Coke contributes to organizations that support, for instance, non-white chefs who have not received sponsorships because of systemic racism. It's laudable for corporations to tackle anti-racism and look for ways to be a part of the conversation and the solution to promote social justice. It's unlikely, however, that a product that is unhealthy can ever shift into becoming healthy. The cigarette industry has tried that with vaping, and we've seen the results. The pandemic has exposed the insidious link between employment in industries that harm our health and the disastrous effect these industries have on people who must rely on sugar-sweetened beverages or on meat packing to eke out a living. We don't need sugar-sweetened soft drinks to survive the pandemic. In fact, we're much healthier without them. A lawsuit in Sacramento by a nonprofit health organization is petitioning that California cities be allowed to pass a soda tax on sugar-sweetened beverages to offset the costs of the pandemic on the state. Is it smart? You bet. How do I know? Because data support the telling of this story. Numbers of studies in peer-reviewed journals have shown that soda taxes can decrease consumption of soda, and that the best way to get a tax passed is not to emphasize obesity and health issues, which many people perceive as finger wagging, but to talk about the social good it will do. Philadelphia has shown this by telling the story of the tax as a means to improve pre-K education. In a recently published article in the Berkeley Public Policy Journal, Farnsworth and McBride argue that the COVID-19 pandemic is illuminating the urgency of this diet-related disease epidemic, as individuals with diet-related diseases are more likely to develop severe complications from the virus. Undoubtedly, the story of the soda tax to help defray pandemic costs will be countered by the American Beverage Association. Their story will be that such a tax is unpatriotic because it takes away consumer choice and imposes a nanny state. You see, it's always about the story and the counter story. And neuropsychology is teaching us a great deal about the story impact, led by Facebook, Cambridge Analytica, and Google. Human beings react emotionally to threats, control, and dread. Anecdotes and conspiracy-based stories that foster these emotional reactions not only promote the doubting of science, but also play into our deepest fears. My area of research focuses on the neurobiology of storytelling. I'm interested in understanding at a neural level how stories affect our brains. Are some stories more impactful? If they are, can we measure neuronal activity? Marcel Just at Carnegie Mellon has been a leader in studying the neuroarchitecture of cognition. Using fMRI scanning, he and his team have asked volunteers to think about different emotions like fear or joy or envy. Looking at the volunteer's brain activity, Just can predict with fairly good accuracy what emotion that volunteer was thinking about based on activity in specific regions of the brain. No, he cannot read our thoughts, but this work is an important step in understanding how stories affect us at the neural transmitter level of the brain. And with this research come vexing questions. As we learn more about how stories shape our emotional and intellectual responses and actions, how do we protect ourselves from being led by those with nefarious plans for, say, political control? Do we stop doing the research? Do we do the research to understand Facebook, Twitter, and Instagram better when we're faced with bots and trolls that want to control our election? Whose story takes precedence? We're entering an era of genetics with CRISPR and a deeper understanding of our brains that will profoundly shape our lives in ways we can't imagine. It's time, I believe, for us to start asking these questions. In the meantime, we have a raging pandemic across the world that calls for new ways to tell stories that move people while revealing the terrible inequities that many people have learned to turn away from in their daily lives. We need to help people listen to the science. We need to make the data clear visually by telling vivid and cogent stories about the meaning of, say, contact tracing. Stories matter. We must back them up with the best data available and be clear about what is as yet unknown. How then can we do this? It's a Herculean task just to develop vaccines, and now I'm asking that you prepare to tell stories as well? Yes, because who best to tell these stories but those of us engaged in promoting public health, whether as epidemiologists, healthcare providers, or health advocates. You know the data. The challenge is to make it understandable and compelling to the public. One way to do this might be through cross-collaboration. We are hearing a lot about collaboration today, for instance, in the pursuit of a vaccine, as if collaboration among universities, pharmaceutical companies, and foundations has suddenly sprung forth for the first time. Clear need has made it happen in a time of crisis. I hope we will learn that collaboration can still work wonders after COVID-19, and that the pursuit of profit doesn't elbow its way in to prevent it. Collaboration across disciplines, not only within one's medical school or school of public health, but with all the schools in one's university, might be one way to tell more compelling stories. Partnerships with divinity schools, design and architecture, and education can reveal ways of telling stories that we may not have thought about. Let's take the work that we're often doing in silos and share it with our colleagues. University-wide collaborations to address problems like obesity, the nature of sleep, or how to redesign entrances and space in schools could have a remarkable impact. COVID-19 has already challenged us to find new ways to teach virtually. With all its tyranny, COVID-19 may also teach us new ways to be creative. Here at Yale, the School of Public Health is drawing on the humanities and arts, as Professor Lichtman said, to promote public health practice. Working together across the university, the School of Public Health seeks to collaborate with storytellers and artists to find innovative ways to promote public health while grounding this work in science. Imagine seeing a play that deals with, for example, someone struggling to sleep, a problem we all can relate to at some time or another. The HAPPY Initiative will take a health-related issue, or problem and explore it from multiple perspectives, drawing on a range of storytelling and art modalities: drama, sculpture, architecture, music, painting, poetry. All of those practices can and should be applied to the trenchant public health problems facing us today. Because, as I've tried to convince you, our best hope for solving these problems is through a marriage of science and storytelling. We also need to collaborate beyond the university to guide policy and program development. Traditionally, we share and explore ideas with our colleagues and through papers and conferences, but those means of communication leave out the general public. One group that could sorely use health professionals' insights are students in elementary, middle, and high schools. Learning the basic science informing public health and the importance of scientific inquiry will help them understand and prevent future pandemics. New and traditional storytelling modalities already exist. One way to begin a storytelling journey post-COVID-19 is to reflect on the work you're passionate about. Share that passion. Inform, infect, captivate. Thank you for listening, and I'm sorry for the little flubs I couldn't show you that one piece, but thank you again.
Thank you so much. I wanted to encourage anyone who might pose a question. We have multiple screens. If you might like to put something into the chat room. In the meantime, thank you so much for bridging across certainly what is going on politically, culturally, and also I think giving us great direction about where we would like to sort of collaborate more on storytelling. Stan, anything you wanted to add?
No, we're just buying into your agenda here, Neil, in a very big way. We should tell people who don't know it, Yale Humanities and Arts are among the best in the world. I mean, there's just no question that they're routinely rated as some of the best in the world. This Happy initiative takes the vision of somebody like you, Neil, and somebody like Judy and Tyga Christie, who's on the phone, and some of our other partners, and it takes advantage of this extraordinary expertise at Yale to make this bridge between health, humanities, and the arts. And you've illustrated in your dean's lecture very dramatically the good and the promise that can come from alternative modes of communication. So we'd like to open it up for anybody who has a question. You can either unmute and shout out or just drop something in the chat. Mayur, go ahead.
Hi, thanks, Dr. Baer. That was great. I'm a non-Emmy Award winning colleague in CDE. But you know, your first clip actually raised a question for me, which is, while I think most of us are in agreement with the sentiment of the clip, it struck me as a very causative in nature, in the tone of it. And how do you balance, you know, something that we're always trying to be very cautious of, and that is trying to oversell causation based on one study, right. Even if we are partial or, you know, agree with that sentiment. And so, right.
Well, you know, what's really interesting about that study is that Felton Earls, who's a psychiatrist at Harvard, posits causality, and it was published in Science. So it's, you know, considered the gold standard. Now, the whole show, to speak to that question, I didn't show you all the clips, it is a retroactive study. So somebody from the NRA is on the stand and says, is that the gold standard? And they have to say, no, it's not. The gold standard would be an experiment, but we can't expose children to gun violence. So he responds by saying something to the effect of, you know, lesser approaches give lesser answers. So in that one clip, we do posit causality, or the defense attorney does, based on the science in that piece, but we were very careful about that. And in the whole show, we did say that, and that was what was really exciting to me, that I could do an episode that talked about different kinds of research studies, which you don't typically see on television. So yes, it's important to be very cautious about that. So I was really trying to show both sides and let the audience see that it is complex. But it was a very interesting piece. That piece kind of drove me to my recent, research, which is, what does it mean that when a kid sees gun violence, actually sees the violence, what does that mean cognitively? And the piece doesn't deal with that. And so that's why I started to look into, the what I call the neurobiology of storytelling, because we kind of often just stop and say, oh, we're hardwired. But what does hardwired mean? And so, if we think about the term catharsis, and we're watching a movie or we're reading a novel, we hear music and we're tense, and then we have that catharsis from the play, Antigone or whatever great Greek tragedy or modern plays. We understand what we mean by catharsis, but I'm really interested in knowing what is the neurobiology of catharsis, so that I understand better how stories shape our actions. But as I also mentioned, I'm very concerned that as we learn more about how our brains respond to stories, that people will be using that research to direct the ways they want people to respond. So it's something that I've been thinking about more recently that really concerns me, because who am I to direct people with my stories? And yet I have the data about public health outcomes. So I know sugar sweetened beverages are harmful. I have all the data. But who am I? That's why I talked a lot about the complexity of Coca-Cola. Who am I to say that people shouldn't have these jobs? So this gets into such complex issues of how do we change jobs and how do we deal with all of this? So this is a long answer to your question, but it really gets at so many issues, that it's not just, we have to tell public health stories to help people feel better. We can take the data, offer them stories, but we have to start thinking about our own responsibility in storytelling too, and what our goals are. It's really going to be complicated as we learn more about the neurobiology and the epigenetics of storytelling.
Thank you so much. We're coming up on the hour. We are able to stay on. Are there additional questions that anybody might like to ask? Either speak up or go into the chat room. I actually had a question for you, Neil. Along the lines of how important the anecdote is, how might you think? So many of us are public health. How do we? What skill sets do you think we need to add to be able to do a better job of telling compelling stories that get traction out in the community?
I think that's a great question. There's been a little bit. There were some folks who've written about this from Penn, in Meisel and Karwish, I think are their names, and they talk about how, for instance, an example would be doing a PSA or mammograms, or even colon cancer now, where they're changing the date from age from 50 to 45. So they're using the data. But how do you tell a story when it's complex? Like, some people agree, some people don't. So that's where anecdotes come in, because people tell their own story. Like, I had a PSA when I was 30 and I had prostate cancer, and if I hadn't had surgery, I would have died. That's a population study really that says you're not going to have a lot of positive results in people under a certain age. But we have to, as public health practitioners, tell people and help them understand the difference between individuals and populations first, because they think that a population study means their personal risk, and it's a population risk, and it's so complex, and that they want to take that and they put it into their own life, and we want that. And we all talk mostly about risk in the work we do. So it's not about the one, but it's about assessing what one's own risk is. So how do we tell those stories? So when I talked about vaccines, I said, there's a website where it encourages people to tell pro-vaccination stories. And so we have to be ready to be transparent, of course, and talk about what we don't know. And we often are talking just about risk, but we have to be really clear so that people can make their own decisions. I have no problem with people drinking soda on occasion, but 1 out of 20 Americans drinks more than 500 calories a day.
Mm.
If you drink 1 soda a day, you'll gain about 5, changing nothing else in your diet, about 5 pounds a year. If the playing field were level and people could make that choice given the information they have, I think that'd be wonderful. But the playing field isn't level. Story after story after story about, drinking sodas is sexy, promoting it for anti-racism conversations, which of course we want to have. The storytelling is ubiquitous. And so I think we have to be able to help people understand the different kinds of stories as well.
Yeah. And a question that came in would be great to get your thoughts. How can we tell compelling stories by avoiding the sort of like the savior complex or exploitation of especially vulnerable populations?
Great question, which is that's, why I brought up the complexity of like sodas. Cell phones have changed everything in terms of storytelling. So now pretty much anybody anywhere in the world can tell their own stories.
Mm.
So instead of imposing our own views on what's right or what's wrong, we can give people who don't have them the tools to tell their own stories and the platforms to tell their stories. So I think it's critically important because, as I said, who am I to say what one person should do or not do, especially in the complex world of economics and jobs. So people should be able to tell their own stories, and we have the tools. So that's another role for us as public health practitioners, is providing those tools, which are really cheap. I made a movie. I gave a camera to an adolescent in Maputo, Mozambique, and taught him how to shoot his own story. He was an orphan whose parents had both died of AIDS. This was about 10 years ago. And it was complicated because cell phones weren't able to make short documentaries then, but now they can. And so he doesn't need a huge movie camera, and he doesn't need all of that. He can just take his phone and do that. And people are doing that, and they're putting it on YouTube, and they're doing it with TikTok. So why not encourage adolescents and young people, young adults, to tell their stories through TikTok and through other social media platforms on health?
No, it's a great point. So let me thank you again for a wonderful talk. I had been asked, the recording will be available in a couple of days. We'll make sure that it's posted. And again, please reach out to us if you have follow-up questions. And we are very excited to have Neil be contributing in many ways and for us to be talking about ways to improve many aspects of storytelling, bringing in all different kinds of disciplines to have an impact. So thank you very, very much.
Thank you. Thank you for having me.
And thank you for perseverance with a few startup issues.
Sure.
Thank you. Thank you. It makes it very real.
It does indeed. Thanks. Be
Thank
well.
you so much. Be well, everyone. Bye-bye.
Thanks. Bye.